think I'll go ahead and get started with some of our introductions and things, because that'll take a minute or so, and then we can get started with the actual presentation. So my name again is Danielle Rios, and alongside Danny Wise, who's my co-chair for the TNE curriculum committee, we would like to thank you for joining in on this session, which I've lost track of which number it is, but they seem to be going well. And we want to just remind everybody there is a chat box and a Q&A box. So the chats can sometimes get a little lost. So if you have a question, please put it in the Q&A box. We can follow it and make sure that it gets answered a lot easier that way. For the trainees that are actually in the panelist group, again, we'd love for you to have your camera on. Do not feel obligated to do that, but you are able to unmute and ask your questions as well. So you don't necessarily have to put them into the Q&A. For those that are watching that are outside the panelists group, we encourage you to put your questions in the Q&A. We will make sure to address the trainees' questions first, but then we will get to all the other questions if time permits. So I would like to introduce our speaker today. So Dr. Amish Jain works as a staff neonatologist and a clinician scientist at the Sinai Health System Lunenfeld-Tannenbaum Research Institute, and as an associate professor in pediatrics at the University of Toronto. He completed his medical school in India, a pediatric residency in the UK, and both his neonatal perinatal fellowship and his PhD in cardiovascular physiology at the University of Toronto. He's also the site director of the Targeted Neonatal Echocardiography program in the NICU at Mount Sinai Hospital. Dr. Jain's specific research interests are in the field of critical care, neonatal cardiopulmonary physiology, and functional echocardiography, particularly in the assessment and management of pulmonary hypertension and right ventricular function in neonates. So we welcome you, Dr. Jain, to the Curriculum Committee Foundation Series, and look forward to your discussion on pulmonary hypertension.
Thanks, Danielle. So hi, everyone. Thank you so much for giving this opportunity to come and talk to you about chronic pulmonary hypertension. I do have a presentation put together, and I'll be sharing my presentation mode, but in the spirit of this particular series, where we want to keep it as interactive as possible, although I don't have any inbuilt polls or any gimmicks to make that take place, but I would be relying on you guys to stop me wherever you think something is needs more clarification, particularly those in the trainees who are actually being given the panelist role. You guys should be completely free to stop me at any time. I will not be looking at the Q&A boxes as I'm talking because of my presentation, but at the end I will go through all the questions that people may have, as many questions as possible, but just stop me in between. Now, I typically, when we're doing live session with trainees, I typically tend to pick up on everybody and sort of put them on the spot. But here it's hard to know, everybody's cameras off. I don't know who's doing what and whether that's doable. But I may ask you some questions, and it would be nice if somebody can volunteer so that we can actually have an interactive session. Otherwise, I'm known to talk a lot. So, okay. So with that said, I'm going to share my screen. Where is it? Here it is. All right. Can everybody can see my presentation? Is all good?
Yes.
Awesome. So our today's session is about chronic pulmonary hypertension. Now, it's a little bit of a long presentation. I'll try and skip certain aspects of it which are not that great or not that important, and then try and limit myself to in a way that we can finish by 3 o'clock so we can have some time for chit chat. First of all, my funding disclosures. I do actually have a investigator-initiated research grant that I got from Mallinckrodt Pharmaceuticals. That doesn't have anything to do with chronic pulmonary hypertension, but it is about pulmonary hypertension or acute pulmonary hypertension in preterm, so everybody knows about that. And then I've got some CIHR, which is a Canadian national sort of granting agency, which are non-profit organizations. So I do actually have grants from them and from Heart and Stroke Foundation, specifically related to pulmonary hypertension in the preterm population. Okay, my funding disclosure out of the way. Let's start with a particular case. This is a real case that I saw, and some of you may have heard me before, and heard about this case, because this was quite some time ago, 5-7 years ago, when I actually got interested in this particular topic. So see whether you can relate to the particular case. So say a 26-week baby who was 730 grams, born, got surfactant, mechanical ventilation for a few hours, got extubated to CPAP, and then was doing well in CPAP room air. And in about second, third week of life, start having spells, FiO2 went up a little bit, basically chronic lung disease, what we often end up calling evolving chronic lung disease coming through, got intubated because of that. Then again, got extubated at about at around 30 weeks or so, with the help of DART protocol, back to CPAP in 21 to 23% oxygen about at 32 weeks. And then over the next couple of weeks, out of the blue, unexpectedly start having more spells, increasing FiO2. And at that time, a septic workup was done, thinking that this baby probably has a infection. Everything came back as clear. You can see from the lung chest X-ray there has a degree of chronic lung disease changes. But at that time, nothing else was coming out. And the kid has developed edema on NIPPV, quite a bit of spells. And that's when the clinician actually asked for an echo. And at that time, in our unit, we were not screening for this particular disease. Their echo request really probably was linked to potential PDA or something else causing respiratory symptoms. And this is the scan that we actually found. And I couldn't really play the video on my office computer, unfortunately, so it's a still image. Those of you who actually do echo all the time probably will recognize this image. This is a short axis image where the bottom, you can see my mouse here is the left ventricle, on top is the right ventricle. And in this particular image, what we are seeing really is that there's a flat septum in systole, and the right ventricle on top of the left ventricle should have been smaller than the LV, but it's quite dilated qualitatively, and in this particular case also quantitatively. So this was the first time I saw this scenario. This was, as I said, 7-8 years back, or probably even more. And since then, once we recognize this phenomena, it is not that uncommon to see patients who are have chronic lung disease develop respiratory symptoms, and also on echo we find that they've got a flat septum in systole, which is pulmonary hypertension, and right ventricle dilatation at that time. And hopefully, I'll doing the presentation, I'll sort of try and put some physiology and some epidemiology together in this scenario. That what do we really see? Then there are some other aspects of NICU where you will, I'm hoping you will relate to this also. In our NICU, certainly there is sort of oftentimes nurses will say that our baby is a real swinger. What they really are trying to say is that there are certain kids who have certain severe desaturation spells, which then recover quite slowly, and they swing quite a lot. Then there will be nurses who are a little bit more sort of detail oriented, will actually inform you that they have noticed that the saturation goes down slowly up to a particular point, say 85 or 86, and then suddenly decline very fast. And if you can catch a spell early and provide oxygen before we reach that particular threshold, then you can minimize that acute drops. And this does happen in ICU. Nurses do note that you can actually prevent a major spell by catching early, right? My hope is that during today's talk, I can sort of put physiology in context here, that what exactly is going on in these kids, why do they behave the way they behave. This is not uncommon either in chronic lung disease patients. My baby has become very puffy, and particularly dependent edema in the groin area, where parents will often, and even nurses will often complain that it's really, groin is huge. And in the extreme scenarios, you end up seeing scenarios where preterm babies late in the course seems to outgrowing their lungs. And by that, what clinicians really are trying to think is that there is a pulmonary hypoplasia phenotype that evolves during an ICU stay, or at least they think is evolving during an ICU stay, because a patient who's been previously okay suddenly starts having more and more oxygenation difficulties. And on echo, oftentimes have pulmonary hypertension on, despite invasive mechanical ventilation, often doesn't seem to recover. And they suspect that the baby grew, but the lung didn't grow. So I don't know how many of you actually have come across these scenarios. I would suspect most of these are not that uncommon in tertiary and ICUs. So what exactly is going on here, right? And we'll get to that in a second. This is another scenario. You can see this is a growth chart of a baby who was born on 10th centile, fell down to 3rd centile in between at some point, and was growing quite nicely on the 3rd centile, and then start gaining weight around 38, 39 weeks. And initially, this particular child, this is again, real case from my ICU. At this time point, at 40 weeks or so, actually, people were very happy that we are making the kid grow. But as you can see, that really wasn't the real growth. And what ends up happening is this kid crossed centiles and became a really volume overloaded and puffy. And by 50th week was up to 50th centile, and that wasn't real growth. This was all volume overload over a period of time. So what I'm going to submit to you is that majority of these phenomena that we are seeing in an ICU are actually linked with pulmonary vascular disorder or pulmonary vascular disease, which in extreme scenarios result in right ventricular congestive heart failure. And hopefully I can put physiology to these cases. So coming back to chronic pulmonary hypertension, I've divided this presentation into a few parts because there are certain things which we know from evidence, and then there are certain things we know from physiology, where there's not a lot of direct evidence exists right now, except for physiological concepts. So what do we know from evidence first? Well, to my mind, this disorder actually gained a lot of traction among neonatologists after this paper came out in 2007. Prior to that, also, there were a lot of people who were studying neonatal pulmonary hypertension or pulmonary vascular disease in mostly animal models of BPD, but it really wasn't sort of prime time. But this paper came out in 2007 from Kimani et al. And this was basically their experience of a referral center, pulmonary hypertension clinic referral center, where they got referrals from the community, and they examined preterm babies with chronic lung disease who was referred to them for pulmonary hypertension at a few months after discharge. And what they were able to show is that on referral, at the time of first referral, if the pulmonary arterial hypertension was recorded to be severe, then there was a very high mortality, almost reaching 65-70% by 18 to 20 months. On the other hand, if it was not severe, then those patients still had PAH. There still was about 20% mortality, mostly in the first few months. And there's a big difference with regard to severity of pulmonary hypertension. Of course, this is a referral center, so it's not reflective of the whole NICU cohort. It's a sick cohort and has some selection bias. But still, what this paper highlighted was that there are patients who are getting discharged from NICU with pulmonary hypertension who seems to get worse over time. And if they do get worse over time and diagnosis is made at multiple months of age, by then, and it's already severe at that time, then those patients have a very high mortality rate. So that was the first time that all of us sort of took notice of this disorder. But subsequent to that, there have been multiple studies, I would say about 60-70% retrospective, but about 30-40% good quality prospective studies, which have established the incidence, or for that matter, the prevalence of chronic pulmonary hypertension in different severity of BPD. As you can see in this particular bar graph, the chronic pulmonary hypertension's incidence go hand in hand with the severity of chronic lung disease the patient has. In mild chronic lung disease cases, the incidence has been reported to be anywhere from, some studies say 0% to up to a maximum of 4%. And here you can say in moderate BPD, the incidence of chronic lung disease ends up being chronic pulmonary hypertension ends up being about 10 to 14% in the range. And in severe BPD, it's really high. It's almost like 55-60% of patients will have evidence of chronic pulmonary hypertension. You put them all together, then you are basically talking about an overall incidence in extremely low birth weight infants of about 30 to 35%, depending upon the incidence of chronic lung disease. So that much we know, that is established. Then there have been systematic reviews of outcomes. This was the first one. One of our friends from McMaster in Canada actually did a systematic review in 2017 and put together the few prospective good studies, and essentially found that patients who have chronic lung disease and pulmonary hypertension have higher mortality, higher need for home oxygen, or higher incidence of need for home oxygen therapy, as well as more respiratory morbidities during in a hospital stay. More recently, this is unpublished data from Dr. Bonnie Jasani, who works in sick kids here in Toronto. He, along with his fellow Dr. Balushi, actually recently conducted an updated systematic review for prevalence and outcomes of pulmonary hypertension and BPD. This is not yet published, and you can see here, they found the same finding, that no BPD or mild BPD cases tend to have 3 to 4% incidence of pulmonary hypertension, moderate 15%, and severe average was 40%, but the range varied from 20 to 60. You look at the mortality, and this is much more number of patients that you can see compared to before. We're talking about almost 3,800 patients on a multiple, so they combine both prospective and retrospective studies together, and you can again see the mortality rate is much higher in BPD plus PH versus BPD alone. So it just confirms. Same thing here. You can see duration of mechanical ventilation is higher in those patients with PH. Duration of supplemental oxygen is also higher, and so is the need for home oxygen. The need for, or the duration of non-invasive respiratory support was a trend, but wasn't significantly different between the two groups. And when we look at their long-term cognitive outcomes, in this particular area, we are still in the beginning to understand. There's not a lot of studies. There's only 3 studies, all retrospective, all with a degree of selection bias, because there are a lot of patients who were lost to follow up. But among those who were followed up, it seems that BPD plus PH patients seems to have lower cognitive scores, language scores, and motor scores at 18 to 24 months assessment compared to patients who have only BPD. In addition to that, their growth parameters at 2 years were also lower. So what did we learn? Basically, we know, and this is not even up for debate anymore. In the last 10 years, that's probably the only thing we have learned for sure, is that BPD plus PH patients have a higher incidence of mortality, higher incidence of respiratory morbidity in hospital, and potentially increased incidence of neurodevelopmental disorders as they grow in the first few years of life. So what is the other thing we learned? What happens afterwards? What is, as you can see this paper, they're calling it, what is the fate of pulmonary hypertension with BPD after 36 weeks? How does it, what's the natural history? And this is a recent article from a single center where they examined the patient at 36 weeks onwards when the diagnosis was made. And based on their severity of pulmonary hypertension, calling it systemic, subsystemic, or systemic versus suprasystemic, they followed them up and was described their course. And again, they found the same thing, just like the Kimani et al. 15 years ago found that higher pulmonary hypertension or higher severity of pulmonary hypertension had a higher mortality rate compared to those patients who had subsystemic or systemic pressures at 36 weeks. And you can see on the left here, that's the criteria they basically used to describe or to catch up their cases. This is the case definition. What happened afterwards? You can see, I really like this graph because it sort of nicely depicts. So this one is the month from time of diagnosis, which is after 36 weeks onwards. And you can see this is only PH patients. All the PH patients had PH and was alive in the beginning, but as time went by, the PH kept getting more and more resolved in about 60% of cases, but 40% of cases continue to die as time goes by. Essentially, what it means, what it demonstrates is that the PH at 36 weeks is associated with high mortality, but if the patients survive, at least on echocardiography, their PH seems to resolve. So the natural history is resolution, and that is a major difference between chronic pulmonary hypertension in this population, which we look after, versus children or adults who have chronic pulmonary hypertension from either cardiac etiology or from connective tissue disorders or idiopathic pulmonary hypertension, those scenarios are not self-limiting. Here, because the time is on our hands, it actually does get better on its own over time. As when I'm so on its own, I mean without direct intervention. But in the process, there is a proportion of patients who also die secondary to their pulmonary vascular and pulmonary disease. So that's where lies the challenge. Okay. More recently, sorry, I'm just going to take a pause here. Does anybody have any questions about what we talked about so far? Any comments? Any questions? Anything not clear? I may be going too fast. No, all good. Okay, then we'll keep going. All right. In the last few years, there is also a sort of increase in interest in trying to diagnose these kids early. And there have been a couple of retrospective studies comparing echoes done earlier versus later and trying to identify, is there a way that we can pick these patients early rather than waiting till 36 weeks, because that seems to be quite late from an intervention perspective. So I've just I'm going to take a little bit of a time on this particular slides. These are the multiple studies. I put the slide together about a couple of years ago, and there hasn't been a lot of change since then, at least in the quality of studies that we have. And you can see these studies actually, their definition of early assessment varied, as you can see on the right side here. It varies from 5 to 7 days, sometime even 3 or 2 days, to all the way till 4 to 6 weeks. So what they did, they scanned the patients, or if retrospective studies, they looked at the scans done on earlier time point and at 36 weeks, and basically compared patient who had pulmonary hypertension at 36 weeks versus those who did not, and trying to identify how many of them also had pulmonary hypertension early. I'm just going to go through the study that are not that great because they were mostly retrospective in nature, had a bit selection bias, large number of patients never had a scan, so were not included, or there was an overall small number. So this is a prospective study, actually, the first one I'm showing. You can see that 120 patients, 10 of them were diagnosed at early pulmonary hypertension at between 10 to 14 days, and 5 of them had late pulmonary hypertension. So there was not much analysis possible given the number of patients they had, but what they did find was that a higher FiO2 on death at 10th day of life or in the first 10 days was associated with evidence of early pulmonary hypertension. And early pulmonary hypertension on the first 10 days was actually a risk factor for eventual BPD. But early pulmonary hypertension was not directly linked to becoming late pulmonary hypertension. But again, as I said, there's only 10 and 5 patients. They couldn't really do much with it. There was another retrospective study. Again, I'm not going to go into detail of it. You can see here that almost on a 2/3 patient never actually had, could not be included because they were never an early echo. But they basically examined the evidence of early pulmonary hypertension on the 3rd and 14th day of life and noted to be 23% in the patients who did get echo. And again, they also found that early pulmonary hypertension was a risk factor of BPD or mortality as an outcome, but was not directly converting into late pulmonary hypertension diagnosed at 36 weeks. Another one, less than 30 weeks, 67 patients, incidence of early pulmonary hypertension, 16%, same finding. Right? If you look at the 4 to 6 week data, these are the patients who were less than 30 weeks, were needing oxygen for more than 4 weeks of age, and hence were then had a scan, and had scan at 28 weeks, 32 weeks, and 36 weeks. And what they found with the prevalence of early pulmonary hypertension at 4 to 6 weeks was 28% in patients needing oxygen therapy, 22% at 32 weeks, and 17% at 36 weeks. Again, could not really found that early pulmonary hypertension at 4 to 6 weeks was a predictor of early or late pulmonary hypertension. Now, I must say, in all these studies, the diagnostic criteria used for pulmonary hypertension was same, more or less. There were mild differences, but essentially they relied on flat septum and systole. In addition to right to left PDA shunt, right to left PFO shunt, or RVSP, more than 40 in some studies, more than 45 in some studies. but majority of patients were based on flat septum. But they didn't use different criteria for early or late. They called the same. So the patient who had a flat septum on day 7 will be called early, or and so on and so forth. All right, what about the other 3 studies which they did found something? So this was a study from one of our friend colleague Phil Levy, where they did a prospective study looking at where babies underwent echo at 5 to 7 days and then at 36 weeks. And what they're looking at here is using a technique called speckle tracking, which I'm sure most of you who are doing echo or reading about echo or functional echo probably understand. Is there is a marker called I'm blanking out, longitudinal strain, and what they look at is they can look at segments of each wall. So what they found was that the intraventricular septum, the systolic longitudinal strain, if you divide them into 3 segments, which is the basal segment, which is right next to the valve, then mid, and then apical, in preterm infants who did not have BPD and did not have PH, there was a drop, or there was the pattern was highest strain at the basal level and lowest at the apical. On the other hand, in patients who had, and this is 5 to 7 day scan, on the patient who eventually were diagnosed with PH, this pattern was reversed. So it was an interesting finding that that even at 5 to 7 days, these patients who develop BPD and PH seems to have a different pattern of systolic strain. Now, this is interesting physiologically, but I'm not entirely, we've not been able to convert that into any sort of clinical, sort of operational threshold, because strain is not yet prime time in clinical care. There's another study by Bhatt et al., which actually looked at 172 patients, 4 to 6 weeks, and then 36 weeks. And you can see here, at 4 to 6 weeks of age, when they were done screened by echo, 9 had pulmonary hypertension, 136 did not. Of those 9, 8 receive oxygen therapy, or supplemental oxygen or some other therapy at some point for pulmonary hypertension per se, and 5 remained persistently having pulmonary hypertension. These 136 patients who did not have pulmonary hypertension 4 to 6 weeks, 17 of them subsequently developed pulmonary hypertension. So really, it's a struggle. How do you identify these patients early? The patient that we pick up early, who we think have pulmonary hypertension at in clinical care, say at 2 weeks, 3 weeks, they don't necessarily continue to have pulmonary hypertension at 36 weeks. So it's a bit of a challenge for us. And when these guys, when this was another study by Morani, which was the largest cohort study done till date prospectively with 277 patients, they looked at basically early PH in day 5 to 7, and then compared early PH to late PH, and they found that early PH on day 7 only had a sensitivity of 62% and specificity of 41% for late PH. So there's a huge amount of crossover. So as I was saying, early PH and late PH don't talk to each other as well. The early PH findings is yes can become no later, and no can become yes later. What we do know is that late PH, which is your typical 34 to 36 weeks PH, is associated with severity of BPD for sure. And it is associated with higher mortality. It is associated with higher in-hospital respiratory morbidity. It is associated with higher post-discharge respiratory morbidity and potentially adverse neurodevelopmental outcome, which yet not been fully established. We also know that early PH at any time in the first week, 2 weeks, up to 4 weeks is a risk factor, or at least an identifying factor for patients who are at risk of BPD and higher severity BPD. And to some extent of those patients will continue to have late PH, not directly. We also know that gestational age and weight, the lower the gestational age, lower the weight, SGA, for example, is a risk factor for severity of BPD as well as the early PH and late PH. Higher lung disease, higher FiO2 early in course is also a risk factor for these 3 things. So that much we know. And that's all we know so far. As far as the higher quality of evidence goes, however, there's an increasing number of expert guidelines, because as typically happens in clinical care, once you've identified a disease and you've established that that disease is associated with outcomes, as clinicians, we are obligated to do something about it in the in the with the aim of trying to reduce these outcomes or reduce the incidence of these outcomes. We don't know whether we can or we cannot, but once you know, you end up doing certain things. So with that concern rising, expert panels have come together in the last 5-6 years, and there are at least 3 or 4 international guidelines published of how to assess and how to manage these particular patients while we are waiting for more definitive evidence to emerge. And I'll go through them in a little bit. What about current practices? There have been a few surveys. I'm going to be sort of doing a little bit of self-promotion here, only showing you the survey that we did in Canada. But there has been another survey which was done in US. But what I really wanted to show was the treatment practices. And this survey we conducted in 2018 to 19, was published in 2020. But we basically conducted 20 sites in CNN. That is, all the large ICUs in Canada participated. And then also a small sort of representative network in US, the Neonatal Research Network, 9 sites from there. And we wanted to understand what people are really doing. And you can see at that time in 2019 or so, the performance of routine screening for CPH was about practiced by half the units in Canada. Another half were not screening. Almost everybody was said that we use echocardiography as a screening tool, which I think remains pretty much standard. Cardiac catheterization, which is another investigation which sometimes is required, was not done much in Canada. Few more sites in US would, or at least in that network, were doing it. But at that time, only 3 sites in Canada actually had a protocol of standardized management approach. The rest was taking it on a case-by-case basis. On the other hand, in US, there was a little bit more. In that network, at least, there was about 50% of sites had some sort of management guidelines. When you go to who they were really screening, a consistent theme emerged that they were screening essentially patients with lung disease. So the patients who were on respiratory support, still needing respiratory support at 36 weeks and have a diagnosis of moderate or severe BPD or chronic lung disease, are the ones who were getting screened, right? Some sites said they're also screening all ELBWs. Some said all screening all sort of ELGANs, or if they've had a previous pulmonary hypertension. But again, I think that is pretty consistent across an ICUs, and I like to know if somebody is an ICU is doing something different. That typically we end up screening only chronic lung disease patient, and they're off respiratory support by 36 weeks. We don't typically screen them. The timing of first screen was again consistent around 34 weeks, 36 weeks. Some sites had 34 to 36. Then there were non-screening sites, there were 12. They said they don't screen, but they only investigate kids by echocardiography in these. So these are the typical signs that they were looking for. Worsening or lack of progress of respiratory status, any signs of congestive heart failure, poor growth, feeding difficulties. That's when they would look. They're not screening everybody, but those are the signs that people were ascribing to chronic pulmonary hypertension. Echo criteria, again, I was a little bit surprised by the result here, but you can see interventricular septum during systole or paradoxical. That was the most common criteria used. And I think all of you probably will agree this is end up being the most commonly used clinical criteria. Anyway, some sites said the second most common was pulmonary to systolic ratio of more than 0.5. So basically more than half systemic pulmonary pressures, which again were primarily diagnosed using IVS septum because that's what most patients have. And then tricuspid regurgitation. Some sites were using RV dilatation and so on and so forth. You can see there were sites which actually say they're using pulmonary artery acceleration time, which is usually shorter in pulmonary hypertension, as a diagnostic criteria. From a management point of view, asymptomatic patients were most commonly managed expectantly or using conservative mean. And you can see here, the conservative measures were quite a bit. Majority of sites will adjust their saturation. We would, some reduce their total fluid intake. Inhaled corticosteroid was there. Diuretic therapy was quite commonly used. Reflux and so on and so forth. But symptomatic patients were more likely to receive or more likely to not be managed expectantly, and either conservative but also specific pulmonary vasodilator therapy were quite commonly used in them. But people were not treating asymptomatic, or as they thought as asymptomatic CPH with pulmonary vasodilator. And again, number of vasodilators were in use, or at least set to be in use. And to our surprise, the most commonly tried vasodilator was inhaled nitric oxide, followed by sildenafil. So that is the practices. To some degree, the practices appear to be homogeneous in terms of screening criteria and diagnostic criteria. And on some degrees, the practice seems to be quite divergent, and that has to do with mostly management and the type of management. And that sort of reflects the quality of evidence that we have right now, where majority of evidence is stuck at epidemiological risk factor business and when it happens, but there's almost nothing when it comes to management. Right. I'm going to enter quite a boring aspect of this particular talk, which is physiology. I might take a 1-minute break here, or a little break, to see if people have anything they want to bring up for discussion so far. Does anybody want to share their NICU's experience of what they are doing, what they have seen, or anything I've said so far that doesn't make sense or wrong? Please feel free to say. See, that's the trouble with Zoom. I can't force you guys to talk.
Hi, Amish.
Hey, Ron.
Sorry, we're making sure we don't have feedback in Iowa. So we just started screening maybe about 2 years ago at 36 weeks, looking at the echoes. We have noticed, though, that we had a couple babies that we're considering misses that actually started developing indirect evidence of pulmonary hypertension right before discharge. We had one baby get readmitted pretty sick. And when we looked back, there were actually some subtle signs that it was progressing and just hadn't been picked up based on how we were looking at the echoes. And this has started us to now do some more of the advanced measurements on echo to look at pulmonary hypertension and RV function. Previously, they would only measure a TR jet if it was available and look at septal positioning.
Right. Interesting. And what exactly are you looking at now, if I may ask?
Oh, I didn't hear you.
Okay. Anybody else? Sorry, Lauren, there was a lot of echo. I couldn't hear what you were saying. Anybody else want to share what their units are doing, and any?
Amish, can you hear us now?
Yeah.
Does that sound better?
Yeah, much better.
So we had started a couple years ago doing routine echoes at 36 weeks corrected in babies with BPD.
Right.
Babies that were sicker, we would start doing echoes earlier. We have caught 2 babies with progressive pulmonary vein stenosis with doing this system. We have noticed that there was one baby that we discharged with indirect evidence of pulmonary hypertension that ended up getting readmitted to the PICU several weeks later, intubated, quite sick. And when we retrospectively looked at the echoes, there were actually some soft findings of pulmonary hypertension that had previously been read as normal. And so because of that, we are now changing our echo protocols to look at more advanced measurements, some of the things that you had talked about. Previously, we were only looking at tricuspid jet if available, and then looking at septal positioning. So hopefully that'll help us catch some of those babies that are progressing.
Right.
One of the things that we're still struggling with is the babies that still have a ductus at time of discharge, and whether or not to do a cath closure or whether or not to follow them. And I'm not sure if you're going to talk about that, but we've had 2 babies now that we have involved cardiology, but have ended up discharging, and with follow-up with cardiology that still had a small PDA with BP on oxygen.
Yeah, no, I'm not going to address the cath closure PDA thing discussion today. I'm more than happy to have a discussion and in the end, but it wouldn't be. There's not a lot of evidence to tell us what to do anyway. But it's an unresolved question at the bedside, even for us here. And how does it interplay with the CPH progression, and then whether we are modulating it or not. Okay, that's interesting. Just out of my curiosity, I was wondering if you want to share with everybody which parameters for early or more subtle parameters you are now incorporating in your echo protocol locally.
So they're now starting to look at TAPSE. We had asked about eccentricity index, but the cardiologists aren't as keen on that one currently. And then trying to look at pulmonary vein Doppler, as well as looking at PVR index. Those are things that were on echoes but weren't previously reported.
Okay, interesting. Right, that's great. Thank you. Okay, anybody else want to say something about their practice or share their experience? Let me ask something. Is there anybody whose unit actually says we do not screen at all? And it is not a wrong thing. I just want to know what people are doing. No, everybody in ICU is looking for pulmonary hypertension in patient with BPD, more or less. Okay, interesting. A few years back, I would have had a few hands go up and saying we don't look at all. But that certainly has been my experience there as well, that more and more units have started looking, even though from an evidence point of view, we don't necessarily know what to do with it. But from a patient level perspective, people do end up looking and managing it in one way or the other. All right, so I'm going to progress to the, as I said, to an extremely boring aspect of this particular talk, which is the physiology rather than evidence. Now, each of these concepts are independent. So each slide will deal with a little bit of a different concept. And there's something I want to share with everybody, because in my view, at least, I think these play a big role in this particular, it play a big role in many other disorders also, but this particular disorder, the chronic pulmonary hypertension, they are really relevant. Let's see. Okay, first of all, why do preterm babies develop pulmonary hypertension more commonly? And the answer lies in the fact that they actually have a smaller amount of pulmonary vascular sort of space. So if you look at the PVR in the prenatal period, the PVR actually is higher in a preterm infant, in a fetus also. And that is because they have much less vascular compartment in the lungs because of they are born at a stage where they are either in saccular or early alveolar stage. And they just, if you have less number of total blood vessels, you're going to have a higher net PVR anyway. So all these patients who we are looking at is between 22 to 28, 29 weeks, where at the most at risk of this disorder, actually are born with high PVR and a smaller vascular compartment. And they, on top of that, when they develop lung disease or vascular modeling, it further increases their risk of increasing their pulmonary vascular pressure quite quickly compared to a more mature, even a term newborn, who may be able to withstand a degree of remodeling without increasing the net pulmonary arterial pressure. So they are actually inherently at higher risk. On top of that, preterm infants, at least, and this is what we thought in the early period, and we don't really know what the early period really means, they tend to have a persistent or recurrent episodes of vasoconstriction in response to the stimuli that they are exposed to, and particularly lung inflammation, which eventually, after an ill-defined and unknown period of time, is thought to result in anatomical changes, which may be pulmonary vascular hypoplasia, or it has been described from autopsy studies as arterial smooth muscle hyperplasia and distal extension of smooth muscle. So their pulmonary arterioles or distal arteries undergo remodeling and become thicker, which further reduces the intravascular sort of space within those distal arterioles, resulting in a net increase in their PVR. So these two things together put them at higher risk. Okay, next concept, and this is something I encourage everybody to think about. Oftentimes I hear people talking about chronic pulmonary hypertension and using the term PPHN in the clinical status. It's not PPHN. PPHN is an acute pulmonary hypertensive crisis occurring in the first 3 days of life, which is the transition. Then there's also acute pulmonary hypertensive crisis that can occur later, with sepsis, pulmonary hypertension, with pulmonary hemorrhage, pulmonary embolism in older people mostly, and so on and so forth. What chronic pulmonary hypertension is a slow rise in pulmonary vascular resistance over a prolonged period of time and presenting at some point after many weeks. So I personally am not entirely sure the early pH that we are recording in some of the echo, that 7 days, 10 days, sure, it's a risk factor for developing late pH or developing lung disease severity. I'm not entirely sure it's the same disease because this late disease is a slow progressive increase, and that is really important because that's what determines the phenotype. An acute increase in pulmonary vascular resistance in a cardiopulmonary setup, which has already had low PVR before, will result in a PPHN type of scenario, which is basically hypoxemia, VQ mismatch, no time for adaptation, and so on and so forth. That almost never occurs in chronic pulmonary hypertension. It occurs only at end stage of that. But the phenotype that we see in chronic pulmonary hypertension actually is because of a slow, insidious increase and the adaptation that comes with it. Okay. I'm sure all of you have seen this slide many times. And this is important because to just keep reminding yourself, because when you're looking at patients who have pulmonary hypertension or appears to have pulmonary hypertension echocardiography, you always have to ask about their alveolar recruitment. Because if the patient is collapsed and the alveolar or the patient is hyperexpanded, both of them will increase the PVR. And what you can see here is basically the total pulmonary vascular resistance is divided by two components, the alveolar component and the extra-alveolar component of the capillaries. So the capillaries come, they go around the alveolar and go away. So there are, both of them are there. And when you have a lung that is collapsed, the alveolar component PVR is actually quite low, but the extra-alveolar component is high because they are kinked. On the other hand, when the patient is hyperexpanded, the alveolar component goes up and the extra-alveolar is low. But overall, the net results in a U-shaped curve. So remember that when you're dealing with patients with pulmonary hypertension in clinical practice, you do have to ask the question and make sure that they're optimally recruited. They are not hyperexpanded or under-recruited, because that will give you a high pulmonary vascular resistance. Okay, another boring concept, completely different. But extremely important. You know what, maybe you guys, why don't one of you guys try and, can you one of you guys explain the concept of hypoxic pulmonary vasoconstriction? What is it? Do anybody know? Or is willing to switch on their video and explain to everybody else? No one volunteering? Danny, am I allowed to pick on people here?
Yeah, you absolutely can, Amish.
I would prefer if one of you guys can at least try. You don't have to have a correct answer, but at least make an effort and you get brownie points for that. Sharon, I'm sorry, you're the only one with your video on. I feel like picking on you. Everybody else is already sleeping, I think. Do you want to try?
I could.
Give it a go. So just think about it. What is hypoxic pulmonary vasoconstriction, and try and put it in context of pulmonary hypertension. What ends up happening?
Oh, hi, this is Pearl. I think I can try as well. Sorry, but go ahead, Pearl. So I think it's when the alveoli is not having one alveoli doesn't have a lot of oxygen, so as a reflex, the blood vessel that is supplying that alveoli become vasoconstricted to shunt the blood to supply the alveoli that has oxygen that is supplying.
That's right. So that's exactly what it is, right? It's a body's adaptive mechanism that all of us have, so not to waste the blood in the lung. So imagine if the blood actually goes to equal amount in the alveoli, which has got low amount of alveolar oxygen to dissociate, then it will cause a big intrapulmonary shunting, because that blood is not going to get much PaO2 rise, right? So hypoxic pulmonary vasoconstriction is this is a phenomenon meant to protect our VQ matching. So when there is no ventilation, there should be no perfusion. so that everything remains matched. All right. But it happens through distal arterioles getting vasoconstricted. Remember, the resistance comes from arterioles, not capillaries, right? So the arterioles can vasoconstrict. However, if you have a lot of area where the alveoli doesn't have higher alveolar or adequate oxygenation, so under recruited, what happens is you will get a lot of vasoconstriction around that to maintain VQ matching, but that will result in a net increase in your pulmonary vascular resistance. And if you have a sustained or recurrent periods of hypoxic pulmonary vasoconstriction, and that is very good data in adult, it actually causes inflammation and proliferation of musculature in those arterioles which have been constructed so many times. Okay. And here is some experimental data. Actually, not experiment. It is experimental, but this is human data. On the figure on the left, what they did was these were human volunteers who volunteered to actually get their pulmonary artery pressure measured invasively, and were given hypoxic gas mixture of 12% oxygen to try and see what happens to pulmonary arterial pressure in otherwise healthy adults. And you can see in hypoxia always causes an increase in pulmonary arterial pressure, but there is a major inter-individual variability, which means there are some patients increase their pulmonary artery pressure only small, others go really high. And that means that it is occurring due to hypoxic pulmonary vasoconstriction phenomena. In this scenario, it's happening all over the lung, but it basically told them that the HPV is variable. So same stimuli may not result in the same increase in pulmonary vascular resistance in all patients. There's also a huge inter-species variability in how HPV axis works and how but what is interesting in this animal experiment is that the species which had the strongest HPV, they developed the worst pulmonary hypertension when exposed to chronic hypoxia. Right? So again, bringing the same point that when you are exposed to hypoxia, especially intermittently or intermittently, but again accumulative, you are going to have HPV come in, and it actually eventually results in pulmonary hypertension development. Okay, so it's important concept to know that our babies who are having hypoxic episode in the first week, 2 weeks, 3 weeks, 4 weeks of life, taking them seriously may ameliorate some of the vascular disorder disease that we might be seeing later. Okay, now coming to the next concept, there's also a relationship between underventilation, so alveolar recruitment, and pulmonary arterial pressure increase. So we just talked about how HPV works, and there is experimental data to say that when your underventilated area of the lung is less than 30% total, right, then HPV is still active, but the net effect of HPV does not increase your mean arterial pressure too much. It doesn't increase much, and your PaO2 remains fine. On the other hand, when your underventilated areas are between 30 to 70%, then suddenly because of HPV, your mean pulmonary arterial pressure rises quite a bit, and your PaO2 drops down. And of course, more than 70%, everything is terrible. That's near complete collapse. So the learning point here is, from my perspective, from a physiologically, is that there are patients who are hovering at a critical underventilated sort of threshold. It may not be 30% because this is experimental. It may be for our babies, maybe 20%, 25%, and so on and so forth. And they tend to have a little bit higher pulmonary arterial pressure, and the PaO2 might fluctuate because of that. And just by increasing that underventilated area a little bit less, or decreasing it by increasing your alveolar recruitment, you might be able to stabilize their PaO2 and perhaps stabilize their mean pulmonary arterial pressure too. I certainly intend to use this quite a bit in patients who are having this recurrent episodes of hypoxemia, which there appears to be secondary to alveolar recruitment, which is I normally increase the PEEP by just 1 or 2, and that seems to stabilize many times. It doesn't always work, but many times. From adult, we know that chronic lung disease in adult, like COPD, for example, or chronic lung disease of adults, it is actually associated with exaggerated hypoxic pulmonary vasoconstriction. Okay, what does that really mean? It means that when you have an HPV activated around an alveolus because of under recruitment, instead of keeping your vasoconstriction only in that alveoli, which will be a normal phenomena, because they have exaggerated uncontrolled, it actually causes a massive vasoconstriction everywhere. Okay, and it is very well associated with lung disease. So what ends up happening is, if you have developed hypoxemia or enough hypoxemia in one area or under recruitment in one area, you get a HPV initiated, and because of the exaggerated effect, you will have a big VQ mismatch because of sudden vasoconstrictive crisis, which then slowly opens up. So what I suspect happens is many of our patients who actually have a little bit of saturation goes down slowly, and then suddenly boom, goes down from 80 to 40 in no time, and then slowly improves with oxygen. I think what we're dealing with there is basically exaggerated hypoxic pulmonary vasoconstriction, where a mild hypoxemia or moderate hypoxemia suddenly induces a vasoconstriction, not just in those alveoli, but across the board, and causes a big VQ mismatch episode, which then slowly, with giving higher PaO2, slowly relaxes. So I think a lot of those scenarios can be abolished if you can reduce the underventilated area. I'll skip that. Okay. There's another thing that we think about, and I'm sure all of you are looking at it from your echo point of view. The echo talks to the echo criteria of pulmonary hypertension talk about mean pulmonary artery pressure. It doesn't talk about PVR. We aren't able to pick that up. So as we all have to remember, mean pulmonary artery pressure is a combination of cardiac output, pulmonary vascular resistance, and pulmonary artery wedge pressure, or PV, basically pulmonary venous pressure, which is called post-capillary. So you can have a higher shunt either from a PDA or an ASD and PFO, resulting in pulmonary arterial hypertension, but that's flow related. Or you can have a reduced diameter of the arterioles, where the net resistance is high, and that is causing pulmonary arterial pressure hypertension. Or in some situations, which is thankfully are much less common in our population, things like pulmonary vein stenosis we just heard about, or left ventricular dysfunction can give you post-capillary pulmonary hypertension, which is basically a higher LA pressure or higher pulmonary capillary wedge pressure, which also will mean pulmonary artery pressure higher. So each time you're looking at a patient who's got high pulmonary arterial pressure evidence, you do have to ask this question: is it high cardiac output? Is it high? Could this be pulmonary capillary wedge pressure related, or is it most likely to be arterioles? Now, cardiac output is the easiest one to know because you can look at the shunts, right? But the other two, you have to just basically have to have indirect evidence and make a judgment. Because if you give somebody who's got a high cardiac output a pulmonary vasodilator, that's not going to go down well. And then similarly, if somebody who's got pulmonary venous stenosis is not going to respond well to vasodilator therapies. Okay. Last two concepts, I promise, but pretty important. What happens? What happens when you have chronically elevated pulmonary arterial pressures, or basically hydrostatic pressure is high in the pulmonary vascular bed? Over a period of time, patient develop pulmonary edema. Okay, because the high hydrostatic pressure will actually result in fluid being leaking out from the capillaries. This leaking out of the fluid will build up in the alveoli, and it will also go into the interstitium of the lung. And that is how the symptoms of chronic pulmonary hypertension present. It presents through pulmonary edema, not by VQ mismatch of PPHN or an acute change. What ends up happening is you get more and more alveolar edema, interstitial edema, reduced lung compliance, and most importantly, increase in alveolar capillary distance. So the distance between the alveolus or the alveolar lumen and the capillary around it, because of fluid leaking out, even if increases, that's going to worsen your gas exchange quite a bit. Okay, and this is the schematic. It ends up creating a vicious cycle. Now, so here what you're seeing here is, this is a capillary, this is the alveolus lumen, interstitium a little bit, capillary going. This area between here is called the alveolar capillary sort of course, and after that is extraalveolar. So the arterioles and the capillary have higher pressure, right, exerted, through which the fluid will leak out in the interstitium. The intercapillary distance, the alveolar capillary distance can increase. Also goes to interstitium here and in the alveolus. The alveolus going basically means that you're going to get pulmonary edema or alveolar edema. But this interstitium will then push back basically because the fluid is building up, it's going to cause pressure on the extra-alveolar course of the capillaries or the arterioles. And then because of that increase in transmural pressure, the intra-alveolar pressure goes even further up. So you ends up being a vicious sort of cycle where higher hydrostatic pressure causes leakage of fluid in the interstitium. And as the interstitium fluid build up, because of that build up, it exerts more pressure on the capillaries and causing the intra-arterial pressure go to even higher and sometimes obliterate them. So imagine if a part of the capillaries getting obliterated because of interstitium pressing on them, same amount of blood is going to get redistributed in a even smaller vascular compartment. And because of that, the pressure inside the vascular compartment even goes higher up. Okay. You can mark my words here. Every single patient who's got chronic pulmonary hypertension in any, and to be my surprise when I start reading about them and learning about them, this is a established concept in pediatric and adult critical care. Wasn't so much well heard of in an ICU settings. But every single patient who's chronic pulmonary hypertension is symptomatic. They have pulmonary edema, and they have to have pulmonary edema. There is no other way of reaching symptomatic pulmonary vascular disease chronically. Okay. So what about the upstream effects? And this is where we were just talking about looking at TAPCs and looking at RV dysfunction markers. The right ventricular adaptation is a key part of chronic pulmonary hypertension and its ability to cause symptoms and its ability to actually cause bad outcomes, so to speak. So, I mean, these are not human, by the way. These are rat models. This is how the rat heart looks like. You can see the normal RV is a small crescent around the LV, as all of you must have seen on echoes. When you have a higher afterload attached to the right ventricle, it can respond in two ways. It can either undergo hypertrophy, which means the walls of the right ventricle becomes thicker and oftentimes is known as it becomes like systemic ventricle. That's how it becomes, and you almost difficult to know which is left, which is right when you do a autopsy or on a cut section. And that is called as homeotropic adaptation, and that's a good adaptation because higher wall thickness ends up producing more, generate more force, which can maintain cardiac output, overcome the afterload, or it can undergo dilatation. Right? When it undergoes dilatation, that is not a good adaptation. It is still an adaptation. The dilated ventricle dilates because it wants to maintain cardiac output despite having higher afterload downstream. And remember Frank Starling's principle: if you pre-stretch bigger, your output increases. Okay, that's why a ventricle dilates, whether it's left because of PDA or right because of chronic pulmonary hypertension. Dilates as an adaptation to maintain normal cardiac output despite having higher afterload. But it does come at a cost, and that is because of this formula of wall stress. Right? Wall stress is the real afterload the ventricular wall faces, and that is inversely related to the radius of curvature. So if you have a thicker wall and smaller radius, you're going to have less wall stress. On the other hand, if you have thinner walls and you got a big radius, well, you're going to have higher wall stress. So that's the downside of RV dilatation. So I would say whenever you see right ventricle dilatation, or in that for that matter ventricle dilatation, as a clinician we have to take it seriously, because that's not going to last there forever if we do nothing. So the end point is symptoms of chronic pulmonary hypertension are mediated through pulmonary edema. Pulmonary edema itself worsens pulmonary hypertension, and right ventricular dilatation is a sign of congestive cardiac failure. It is basically a cardiac failure with normal ejection fraction. Okay, so these patients who swing a lot, in my view, they basically are telling you that they are having hypoxic pulmonary vasoconstriction from borderline under recruitment. Those patients who drop down quickly, rapidly, with complete, like in major crisis, and come up slowly, they most likely are having exaggerated HPV. And those things you can obliterate by trying to reduce the underventricular area. That patient who's got a huge groin and is extremely puffy and dependent edema is most likely have congestive right heart failure and increased central venous pressure. And the baby who outgrows its lungs It's not outgrown his lung. It's basically suffering from severe RV failure from chronic pulmonary hypertension. Has the lungs, just the quality of pulmonary vascular remodeling is resulting in RV failure. That's what I think we are looking at in an ICU setting. And once we start thinking in the right way, we might be able to do something about it. However, there's a problem. Our problem is that there's a major diagnostic dilemma. All our patients have lung disease. All of them have same symptoms. So these signs that you're seeing here, I'm not going to go through them. They are basically from Wikipedia. So if you look at the Wikipedia page of pulmonary heart disease in adult, which is what this phenomena is called, these are the specific signs. Now, none of these we can actually pick up in our babies. So a lung disease being alveolar compartment, alveolar problem, where pulmonary hypertension is just an innocent bystander versus a pulmonary hypertension that is itself contributing to symptomology, is not easy to distinguish based on clinical judgment alone. I think we've done a lot of this already. I'm going to go by. So now, when you look at diagnostic criteria, as I was just saying before, these just two examples, everybody come up with this composite in studies, but the truth is that in the end, it's the flat IV septum, because that's what majority of patients have. The shunts, the TRs are only present in 20-25% of cases. Everybody else getting diagnosed by septum. But this diagnostic criteria of flat septum is very effective because we can diagnose everybody. It's always there. It's not very sensitive for small changes. And I don't think it's sensitive enough for early diagnosis. And unless we invest some time in trying to develop early diagnostic criteria in a systematic fashion, we won't be able to actually, for sure, identify these patients that early on. There's also a problem. There's a variability in phenotype, as we just talked about. The propensity to develop pulmonary hypertension or tolerate excessive flow varies. Not each 24-weeker is same, not each 25-weeker is same. Their capacity of pulmonary vascular bed is different. Remodeling is very interesting. Remodeling of pulmonary vascular bed will result in increased pulmonary artery pressure, but it is also protective against edema. So if you have a lot of thick pulmonary vascular vessels, you might not have that much pulmonary edema. And same thing applies for right ventricle. Majority of patients will have some degree of hypertrophy and then dilatation, and the combination of the two may determine. I'm not sure how much time we have, but this is probably the last concept. Okay. Anybody? Just so that I can see some more faces. Anybody want to tell us about the difference between compliance and resistance, and how does it play a role? What is compliance and what is resistance? Anyone? I see Sharon, you still stop your video, thinking I'll pick on you. Sagi, do you want to say? Maybe Meher, you want to talk about it? Nope. All right, guys. I'm going to carry on. This is the problem with Zoom. Can't force you. So what we're talking about from compliance and resistance, there are two separate aspects of afterload. A compliance is basically the ability, because cardiac system works, is a continuously changing. Like it's not a static system. You have you have a heart pumping in the pulmonary artery. A big chunk of blood comes out in the pulmonary artery, and then there's nothing else coming out. And then so each beat has a dynamic component. The afterload that the heart faces changes during that dynamic component. It's not the same in the beginning of cardiac cycle or the beginning of systole to the end of systole. And that dynamic component is called compliance. And it is basically the large blood vessels, the first 5 branches of the pulmonary vascular bed, is that what determine compliance. And more simplistically, it's the ability of the pulmonary artery to actually, when the blood comes out, to accept that blood and distend, keeping the pressure that the heart is facing, same or low. So if a poorly compliant pulmonary arterial bed will actually be more stiffer. So as the blood comes into the pulmonary artery in the beginning of systole, and as the volume goes up, the pressure that the ventricle is facing within the systole itself will change and increase. And that's compliance. On the other hand, the resistance is the one which is determined by the end arterioles, and that's the static component. So PVR is resistance. Compliance we can't measure. We just don't think about it. We have no way of, from an echo at least, and it can only be measured by catheter, and that too through quite a troublesome algorithms. So a lot of people are working and trying to identify, and the reason is that the compliance plus the resistance together is what is called impedance. That determines your net afterload that the heart is facing, not just PVR, not just the resistance. And one of the reasons why we may not be able to always pick up patients with pulmonary arterial hypertension if we keep looking at PVR markers is perhaps their compliance is different, which we aren't able to actually right now identify. And there is data to show that in the early stages of the disease, even a small increase in resistance causes a big reduction in compliance. So in the early stages, compliance appears to be more important and goes down quickly, while after a certain time point, it's only the resistance that determines afterload, no longer compliance, because it already reached at lowest possible. And so if we are talking about early disease, we've got to think about both these factors and try and understand, is there a way of identifying which pulmonary arterial bed will be poorly compliant? And at this time point, we don't have it. But it's important to note why not every patient behave the same way, because of the variability. Okay, talked about that already. There's a lot of knowledge gap that we currently have, right? One of the big things is what constitutes significant pH. We don't really know. So what we end up doing is, at this time point, we think significant pH is the pH which is giving patients the clinical symptoms. And as I said, there's a big overlap between lung disease, alveolar component versus vascular component, because symptoms are very similar. So you have to define symptoms. You have to look at the patient and say, this patient, if have a pH, these are the symptoms that I think, whether it's because he's not improving on the CPAP or whether it's getting worsening, and then you can at least have a treatment sort of goal. What symptoms are you thinking will improve by resolving the kid's problem? So we tend to use that a lot. We tend to define the symptoms before we do anything. One option that we have used at our centers, and it's more to basically find a way to be more specific than sensitive, is to use RV dilatation as a marker of significant disease. And as I said, RV dilatation is almost associated with pulmonary edema and higher end diastolic pressure. So not to say that if you don't have RV dilatation, the disease is not significant, we can't say that. But for sure, if you have RV dilatation, you are likely to have systemic congestive heart failure. And if that is the case, pulmonary edema is a part and parcel of that. So we do that a lot. Patient with CPH, if they have RV dilatation, we treat them. If they don't, then we are a little bit more hesitant and we watch them more carefully. Simply because we're not sure in those scenarios, is it a significant disease causing symptom itself, or is it just a marker of the lung disease and it's just going to sit there and it's not really a sort of treatment, amenable to treatment at that time point. As I said, so one of the things we use in clinical practice a lot in our centers is basically diuretics for congestive heart failure. And as I was just saying, your increased hydrostatic pressure causes pulmonary interstitial edema and alveolar edema. And this interstitial edema itself causes increased hydrostatic pressure, and you end up going this circle. If you can treat that pulmonary interstitial edema by causing an acute diuresis, we might be able to break this cycle and at least cause improvement in clinical symptoms, and to some degree improve the pulmonary hypertension progression. And this is the same patient we talked about, but as I showed at the beginning, and you'll see what happened here. This is the patient where we did the echo, and echo here, FiO2 has gone up with a lot of fluctuations. We gave him diuretics after looking at congestive heart failure sign, and you can see the drop down in his FiO2 quite dramatically actually. And his repeat echo looked like this. Same picture, same kid, just after 5 days of acute diuresis. And it did seem to improve quite a bit. I'm not going to go through that, but basically what we have developed is a clinical practice algorithm where we screen, just like everybody else was saying, at 36 weeks, following which, if they develop RV dilation, we treat them diuretics, and only after a lack of improvement with diuretics, we give them sildenafil. And we published data of the first 2 years, and basically what we found was that by using this algorithm, we only had to use sildenafil in a small proportion of cases, and we haven't had a mortality from pulmonary hypertension per se in the 4 years that we've been doing it so far. This is a pre-post echo data showing that by just after a week of diuretics, the pulmonary artery acceleration time improves, the ascending index come down, and the TAPC increases. These are the same patients pre-diuretics and within a week after starting diuretics, all patients with pulmonary hypertension. So it does seem to improve their pulmonary hypertension markers. I must say it doesn't work in everybody in terms of long term. There are patients who persist despite that, and they are the one we treat by vasodilators. Okay, I'll end with sharing you the guidelines. There is a American Heart Foundation guideline. They say that you should screen infants with BPD with echocardiography. They do tell you in detail that how these patients should be evaluated. Think about assessment of hypoxemia, so reduce hypoxemic episodes. Evaluate them for aspiration, airway diseases, and improvement in respiratory support. And then finally, chronic pulmonary hypertension drugs, ideally after catheterization in some cases. But basically, think about flow, think about LV dysfunction. So they give you a clear guideline what you can do. So anybody can go to this paper and look in detail. This is pulmonary vascular disease, pediatric pulmonary vascular disease network from Europe, gives you a nice algorithm, talks about echo and NT-proBNP, and if it is positive, do diuretics first. Only after that, if it is still worsening or borderline, then start sildenafil, and then after that, bosantan. And they have given an updated guideline also recently, same, telling you when to do cardiac. This is what we typically end up using in clinical practice, because we don't go for catheterization early. We only do it when sildenafil fails. But there are guidelines out there that you guys can refer to. And I think with that, I'm going to stop. There's not a lot in terms of management or treatment in terms of evidence, but there's a lot of physiology at play here. And what we certainly can do is take these physiological concepts to the bedside, and from each patient basis, try to individualize this particular patient population care as much as possible, while we're still waiting for a more definitive treatment trials and stuff to come out. Okay.
Thank you so much for that talk. So unfortunately, we are running a little bit over, so we understand if people need to leave, but I want to get at least a couple of minutes of questions if you're up for it. And I think one thing, just one point that I would like to ask you about to clarify is the use of the septum being flat in end systole. Now, because that's a relative measure of LV to RV pressure in a baby who has systemic hypertension, where the LV would be, which could change kind of the dynamic of the RV and LV pressure. Do you check for that when you're doing your echoes to make sure that there's not some outlying that could make the RV?
You mean the septum strain?
No, just if you're, unless I was misunderstanding, but it looked like just looking at the septum, whether it's round. Because there's, LV to RV pressures different.
Yeah, I understand what you're saying now. So basically, there is a small delay between the onset of systole, a very fraction of a second delay in the onset of systole between the RV and the LV. And so oftentimes in early in systole, you will find that the RV contraction starts a little bit sooner than the LV contraction and cause hypertension or a flattening of the septum, so to speak. In pulmonary hypertension, particularly if you have a high afterload, the RV systolic time increases as a response, and that also can produce a flat septum because the LV is in diastole while the RV is not. and this has been described in quite nicely in cardiology journals called RV kick. They call it the septum kick, which actually is a bowing just for a fraction of a second. So is that what you're trying to say, Daniel? Was the question that?
Well, those kinds of questions, and then also if you're really, if you have, high systemic hypertension in your LV, even though you have pulmonary hypertension, your LV may overcome that and stay round.
Yeah, so that is indeed true. And a lot of these patients do have higher pulmonary, higher systemic or higher systolic blood pressures. And yes, you do take that into context. So the systolic blood pressure is 110. A round systolic septum doesn't rule out a pulmonary arterial pressures being 40 or 45 for that matter in that particular setting. All you can really say is it's likely to be less than half systemic. But yeah, that is taken into account. I mean, like anything else, you just have to use your judgment a little bit.
Yep. So for all our trainees, if you want to unmute yourselves and ask your questions. Okay, so we'll go to some of the questions over in the Q&A box, and a lot of them were just about, I think you asked Lauren, and I don't think it ever got specifically answered, but what kind of other measurements other than just the TR jet and the septum being round are people using or are you using, including, and you did talk about TAPSE a little bit, but RV strain or LV strain, tissue Doppler, those kinds of things.
Yeah. So I'll be very brutally honest with you guys. All those markers are very good to talk about, but in actual clinical practice, how many of them have percolated into clinical practice, I'm not entirely sure. Strain is very exciting, but is very user unfriendly at this time point. It takes a long time to do it, and there's a bit of, and it is not yet validated for preterm population on a clinical basis. So it is still work in progress. TAPSE is for sure, but TAPSE again is a marker of RV longitudinal function, and it can also go down simply because of high afterload and doesn't really mean that the patient, the RV is yet completely struggling. What is the threshold of TAPSE where a treatment may make a difference? We don't yet know, but we certainly use it on a longitudinal basis. So somebody whose TAPSE has gone down over a week or 2 weeks, we certainly are more worried about that. PAT is quite exciting, I think, simple and exciting. We still don't know what the PAT exact cutoff criteria should be to diagnose significant pulmonary vascular disease. So we are currently doing a study on looking at the value of PAT and TAPSE to diagnose early pulmonary hypertension. So hopefully by the end of the year, we'll have some of that. But I certainly use pulmonary vascular disease as a separate entity versus clinical pulmonary hypertension. That's how I use it in clinical practice. I ask the question, does this patient has chronic pulmonary hypertension by definition? And by definition is the definition that has been shown to be associated with adverse outcome, which is more than half systemic pulmonary pressures, or at least more than 45. If the patient doesn't have that, which means septum is flat in the absence of hypertension, then I ask the question, does the patient have pulmonary vascular disease? Any evidence of pulmonary vascular disease? There I'm looking at notching in the pulmonary artery Doppler or short PAT, or potentially PAT being TAPSE being a bit low. And if that is also absent, then I basically say this patient doesn't really have much issue. Everything is clear. And if that is the case, then I normally report to my colleagues saying, not a chronic pulmonary hypertension diagnostic criteria yet, but has evidence of pulmonary vascular disease, worth monitoring every couple of weeks to see that it progresses. That's how I do it, rightly or wrongly at this time point.
Great. And what about TDI? Do you use TDIs?
No. The short answer is no. I don't.
And then I guess one other just broad concept. We all have different NICUs that see different babies of different gestational ages. So in the NICUs where they may see 22, 23 weekers, waiting for 36 weeks post-menstrual age is quite a long time. Do you have any thoughts about
we do. I mean, our NICU here has the most 22 weekers in Canada per se. For example, we've had about 10 to 11 every year who reach. Yeah, I understand what you're trying to say. I mean, the pulmonary vascular disease assessment at 36 weeks is a long time, but again, it depends upon the symptomology of the patient and what we're trying to diagnose, right? At this time point, the diagnostic criteria for chronic pulmonary hypertension is the same at 36 weeks, but because that's when we make the diagnosis of BPD. So in a 22-weeker, we are not calling them BPD at 29 weeks, right? We are still calling them evolving, even though the same time period exists. But if they develop earlier features and are symptomatic and you have to treat, then that's chronic pulmonary hypertension, whether it's 36 or 32 weeks. So in our unit, we end up doing a lot of echoes at 32 weeks these days. And that's not because it's a policy, just people have just got used to it so much, they start asking earlier. I personally, 22, 23 weekers, yes, I understand. I have seen those patients develop RV dilatation and flat septum at 31, 32 weeks, but majority of the patients don't. The patients who present that earlier are usually the ASD or flow-related pulmonary arterial hypertension who present at 6 to 8 weeks, in my opinion, at least. There's no real evidence right now to say when they should be screened. We basically tell the clinicians whenever their lung disease or their symptoms seems to be not keeping with lung disease after the first 4 to 6 weeks of age, that's when they look for it.
Great. I can tell you at Iowa, we do try to screen by 8 weeks if it's before 36 weeks, just to kind of get an idea of what, the baby like at that point. But there's there's not a guideline, right? There's not a protocol. And
no, it will be worth looking at that experience and seeing what we are picking up. And the goal is not necessarily only pick up a flat septum. The goal is to pick up a symptomatic kid as early as possible, where we can treat and make them asymptomatic. Asymptomatic prophylactic treatment will have to wait till we have trial evidence for it. In the meantime, we are treating patients who are actually having symptoms from it, right?
Yeah. And then do any of our trainees, have you thought of any questions? Just a couple more from the rest of the audience. So which diuretics do you use routinely?
Right. So yeah, I know in an ICU you say diuretics and you usually get jailed. Because we, at least in my practice, we are starting late. We are starting when patient already has pulmonary edema, because we want to be really specific and pick up patient who definitely will benefit in terms of symptoms. I tend to use loop diuretic for 3 days. And I tend to use a decent dose. So 1 milligram per kg once a day doesn't work, loop diuretic. So what I want to make sure is when we are giving it, we want to make sure the patient actually has diurest, which means they have lost a bit of weight in the next couple of days and the urine output does go up. So otherwise, there's no point in giving diuretic, nothing happened, and then calling it a diuretic failure. So we use I use 2 milligram per kg sort of orally, or 1 milligram per kg Q12, because oral furosemide is half bioavailability than IV. So most of these patients are oral. So 2 milligram per kg twice a day for just a couple of days to make that acute diuresis take place. And if that acute diuresis happens and symptom also improve, then because we don't want to give chronic furosemide therapy with the risk of electrolyte imbalances, we end up putting them for maintenance on aldactazide. That's what we do right now. Again, not dependent on a lot amount of evidence, but this is what us and our local cardiology colleagues actually agreed on.
Okay, and the last question you see in our, there's another one, but Q&A is about myocardial performance index. And do you know of any validated differences between acute and chronic PH with looking at that?
So the TI index is a very interesting thing. Invariably, in every single study you try and do, it shows a difference. It always shows worsening with or a higher number with disease. But even at least in adult and pediatric population, it's never worked out enough to lead to a clinical practice guideline. So we don't really use it clinically. I am 100% confident if I measure it, it will be greater in patients with pulmonary hypertension, acute and chronic. Almost always is. But we don't use it clinically per se, because just don't know what to do with it.
And then the last question, well, two questions are kind of similar in that babies that you put on diuretics will get some electrolyte imbalances. Their chloride will drop, and then the diuretic won't even be able to work because that's what it uses. So
this is primarily why we've come up with furosemide only for a couple of days to cause acute diuresis, and then change to aldactazide rather than higher dose. I certainly have seen hyponatremia when we have tried furosemide for longer than 2 days, or higher dose aldactazide. We try to avoid that. We did publish, and I didn't go into detail because there was not time and it's not really relevant today, that we did publish our electrolyte data after using that. Typically in this patient population, the moment they have diuresed and symptom improve, we change them to aldactazide. We don't see their hyponatremia that much. Yes, there are occasional patients, and we end up giving them sodium because we have to. But we do change them to aldactazide, and then that seems to, as long as you're not, aldactazide up to 4 milligram per kg does cause hyponatremia for sure, 100%. But we try and keep it to 2, maximum 3 per day.
And just,
yes, that's the problem.
Will you clarify what aldactazide is? Because I don't think it's available in the US for those that are in the US.
It's basically spironolactone and chlorothiazide combination.
Right.
It is considered to be, it's one of the potassium sparing diuretics. So it doesn't cause hypokalemia.
And it probably doesn't cause hypochloremia as much either. So
no, it doesn't.
That's one difference.
As I said, up till 2 milligram per kg per day is what the lowest dose we use, and we seem to get away with most patients with that, and that doesn't seem to cause any electrolyte imbalance. The moment we go beyond 3 per day, so because the highest dose is 4 allowed, almost always the moment you go 3.5, 4, it does cause hyponatremia, but I prefer to use combination in severe cases, slow doses in combination. But if that happens, then oftentimes we end up going on sildenafil and stuff like that because the disease is so bad that we're needing higher dose. But you can't leave a kid hyponatremic. Right. you have to correct it.
And then just one thing to think about for the fellow who asked us the question about the sodium chloride is that you can also supplement with potassium chloride for those that if you don't have the aldactazide, and ultimately because it will start, the diuretics will start losing K instead of sodium, your sodium will slowly go up. It just needs to kind of re-equilibrate in the kidneys. So if you are concerned about giving sodium chloride for the, broader retention effects, that's something to think about as well. Any of our trainees think of anything in that conversation? Okay, well, thank you again, everybody. I'm sorry for going over. But we are happy that we did get to at least have some discussion. So we look forward to seeing you next month.